Hello, everyone, and welcome to the latest webinar from PDC Mums and Bumps. This one is on pregnancy with type 2 diabetes. My name is Caitlin Parker. I'm an accredited practicing dietitian, a credentialed diabetes educator, and I live with type 1 diabetes. Today, we've planned to talk about a few different things. We'll start off with an overview of diabetes, particularly in pregnancy. We'll talk about what to expect through the weeks. We'll go through the nutrition and exercise management tools. We'll talk about monitoring, medications, and then also birth and postpartum. So starting out with talking about what type 2 diabetes is. So type 2 diabetes is when the body becomes resistant to insulin and then the pancreas can no longer produce enough insulin. So what we've got here is a picture of a body without diabetes. When our blood sugar level increases, so this may be when our liver releases more sugar or when we eat a food containing carbohydrate, the pancreas makes and releases insulin, which is a hormone that functions like a key. The insulin opens the door to our cells, so these could be any cells in your body, so that the glucose or sugar can go into our cells and we can make energy. When we have type 2 diabetes, what they think starts it is the body becomes resistant to insulin. So if you think of it as the body building a wall here that blocks the action of insulin or makes it less effective. Or if we think of insulin like a key, the lock on the doors of the cells become rusty and they don't really work properly anymore. Initially, the body works to overcome this by making more insulin than it normally would in order to keep that glucose moving into the cells. But after a while, the pancreas can no longer make enough insulin to keep all of that sugar moving into the cells. If the sugar can't move into the cells, it stays in the blood, which causes an increase in blood sugar levels. In pregnancy, this process is almost amplified. So not only do we have the pre-existing insulin resistance that was there before pregnancy, but the placenta, which produces hormones which help the baby grow and develop, those hormones also increase insulin resistance. So it becomes even harder for the body or for insulin to move sugar out of the blood. And it means that blood glucose levels may be higher than what they would have been pre-pregnancy. This is a graph which can be helpful to explain how this insulin resistance progresses through the pregnancy. So if this is our standard insulin requirement or a standard amount of insulin in our body, generally in the first trimester of pregnancy, our insulin resistance decreases or we need less insulin. After about 20 weeks, your body starts to require more insulin, and that continues to increase until around 34 to 36 weeks, where it plateaus. And then as soon as that placenta is delivered, we're no longer getting the hormones that it's making. And so our insulin requirements dramatically drop, often to lower than what they were before pregnancy. When we look at our blood glucose targets, what we're trying to do is keep them within our target ranges to reduce the risk of complications for both you, the mum, and the baby. The criteria for these blood glucose levels is often tighter than it is outside of pregnancy. So our HbA1c, or our 3-monthly average, we're aiming for this number to be less than 6.5% prior to conception and during the first trimester. As the pregnancy progresses, we're aiming for this number to be less than 6%. If you're monitoring your blood glucose levels with a glucometer, the fasting reading, we're aiming for that to be between 4 and 5.3. If you do a test 1 hour after a meal, we want this number to be between 5.5 and 7.8. And then 2 hours after a meal, we're aiming for this number to be between 5 and 6.7. If you use CGM or a constant glucose monitor, our target range is 3.5 to 7.8, which is slightly lower than what it is outside of pregnancy. And we're aiming for our blood glucose levels to be within this range for more or for at least 70% of the time. As we said, we want to stick to these targets as much as we can. And the reason being is that for the mum, it reduces the risk of requiring a cesarean delivery, reduces the risk of preterm delivery and preeclampsia. For the baby, it reduces risks of large birth weight or macrosomia. It reduces the risk of breathing difficulties after delivery and low blood glucose levels after delivery. When we look at becoming pregnant, it's important to make sure that our health is well managed prior to pregnancy. So, as we said before, our target HbA1c is slightly lower than people who are not pregnant. We're aiming for this to be less than 6.5%. You can discuss your medication options with your GP or your healthcare team and ensure that the medications you are taking are safe to continue taking during pregnancy. And if they're not, looking at alternatives which may provide you with the blood glucose control that you're looking for. For people with diabetes, they recommend a higher dose of folic acid. So we're looking for usually between 2.5 and 5 milligrams, which is a lot higher than what is recommended for people without diabetes. We want to start this 3 months prior to conception and continue taking it for the first 12 weeks. During this time, you also want to complete your baseline screening for your diabetes complications. So this is getting someone to check the blood vessels in your eye, making sure that the blood supply and the nerve function in your feet are checked, and also making sure that your kidneys don't show any signs of diabetes complications. The eye check is usually done by an optometrist or an ophthalmologist. Your feet are checked by the podiatrist, and your GP will usually check your kidneys with a blood test. Moving on to what to expect during the weeks. So our first trimester is weeks 1 to 12. This first trimester is a huge time of development for your baby. So it's where they start to make their organs and other body parts, and these organs start to function. The umbilical cord and the placenta develop. And this is often where we start to experience unpleasant symptoms like morning sickness, as they typically call it. The vomiting, nausea, food aversion, and fatigue can make it a little bit more difficult for our diabetes to be managed. We also have that change in the insulin sensitivity. So you may find that your blood glucose levels run lower than they normally do. With our morning sickness, usually this is in the first 12 to 14 weeks, but different to what the name suggests, it can happen all day. Things that can be helpful are avoiding fatty, rich, or strong smelling foods, eating slowly, having smaller amounts of food more often. Dry foods like crackers or toast first thing in the morning, often before you get out of bed, can be helpful. And making sure that you keep up your fluids. So sipping on fluids throughout the day, and sometimes icy poles can be helpful. Full sugar or sugar-free, depending on what your blood sugar levels are doing. If your nausea is becoming unmanageable, it's not something that you have to just put up with or get through. Make sure that you speak to your doctor, because there are medications that can be prescribed to help you manage that nausea. During the first trimester, there are certain tests and scans that we get. So we have the routine pregnancy checks, which are a dating scan at around 6 to 8 weeks. You have a full blood screen, usually ordered by your GP. And then at around 12 weeks, you'll get the first trimester screen. So there are two options available, the NIPT or the NT, blood test and scan. So the NIPT is the blood test, and that's where they screen for chromosomal abnormalities, and it can also show the baby's sex. The NT is a blood test and ultrasound that assesses the risk of the chromosomal abnormalities. Moving on to the second trimester, so weeks 13 to 27. Most people say that this one is the most enjoyable trimester, so you start to feel a little bit more like yourself. You'll be able to start to feel your baby's movements during this time, and that umbilical cord is fully developed at around 16 weeks. We talked about this chart before. So, first trimester, we had a decrease in our insulin requirements, and then they progressively rise from about 16 weeks, especially after 18 weeks. And like we said, it's because of those hormones made by the placenta. So, our insulin requirements continue to rise throughout that second trimester. At 20 weeks, you'll get the anatomy scan, and this is where you can find out the gender of your baby if you opt out of the NIPT test in the first trimester. They'll usually do a baseline growth scan at 24 weeks, but this can vary depending on your medical history. And they may order some other blood tests depending on your risk factors, but your healthcare team will let you know what these are. Moving on to our third trimester. So the last part, this is weeks 28 weeks onwards. So this is where our baby is growing, developing fat, practicing movements and reflexes. Often this is where you start to feel tired and you may have some digestion issues, so particularly things like heartburn or constipation. Movement can become more difficult, and swelling is common but shouldn't go unchecked. Looking at our chart again, our insulin requirements continue to increase up until around 34 to 36 weeks where they plateau. Our routine tests during the third trimester. So at each of your antenatal appointments, they'll do things like urine tests, blood pressure, and weight. If you don't use insulin, you'll have an additional growth scan at 34 weeks. If you do use insulin, you'll have additional growth scans at 28, 31, 34, and 36 weeks to check the growth and the amniotic fluid. And you also may be recommended to have a CTG after 34 weeks, depending on your past medical history. So this is where they look at the baby's heart rate and movement. Moving on to talking about our treatments. So the treatment options are blood glucose monitoring, and there are a number of different ways that you can do that. Diet and lifestyle modification, and then you may also be required to take medication, which in pregnancy is often metformin or insulin. So with our monitoring, often it's done with a glucometer or blood glucose meter. And if you don't have one or it's older, your diabetes educator can provide this to you, or you can purchase one from the chemist. They will also make sure that you are registered with the NDSS, which is the service which provides you with discounted test strips. Usually, we're recommended to test 4 times a day, but this may be changed based on your requirements. So So the target blood sugar levels for non-insulin users. So breakfast, we want it to be, before breakfast, we want it to be 5 or less. If you choose to test 1 hour after the start of the meal, we want it to be 7.4 or less. And then 2 hours after the start of the meal, we want it to be 6.7 or less. If you use insulin, the fasting target is 4 to 5.3. 1 hour after the start of the meal, we're looking for the number to be between 5.5 and 7.8. And then 2 hours after the start of the meal, we're looking for the number to be between 5 and 6.7. The other option to monitor blood glucose levels is a continuous glucose monitor, or CGM. So this is where a device like this one here measures your interstitial glucose level every 5 minutes, and then it gets sent to your phone. So the interstitial glucose level is the amount of glucose that is between your cells, and that can be used to estimate our blood glucose levels. You can set it up so that it can alert you when your blood glucose level is high or low. And it's certainly not necessary, but it can be helpful. So currently, there is no subsidy for people with type 2 diabetes. If you're looking at paying for this privately, the Libre 2 Plus is $102 for 15 days, and the Dexcom One Plus is $65 for 10 days. You may choose to use this a few times during your pregnancy to get a look at what your blood glucose levels are doing, or you may choose to use it all the time or not at all. Talking about diet and lifestyle, there are some things that we can do to reduce our insulin resistance or help that lock on the door of the cell to work better. There are some modifiable factors, but often our age and our genes play a role in this insulin resistance as well. So we want to make sure that we're getting enough good quality sleep. So aiming usually for between 7 and 9 hours, and making sure that the sleep is good. We want to manage our stress, so look at strategies to reduce our stress levels. Regular physical activity, and we'll talk about this a little bit more later. But typically, we're aiming for 150 minutes of moderate intensity exercise each week, at least 2 sessions of resistance or strength training. And we want to break up our sedentary time. So stand up and move every 30 to 60 minutes. Not smoking can help to improve your insulin sensitivity, and also our diet. So including enough fiber. So the NHMRC recommend 28 grams per day. Fiber is found in lots of different foods, but typically fruit and veg, nuts and seeds, lentils and legumes, and whole grains. We want to make sure that we're not having too much saturated fat. So this is the fat typically found in animal fats and takeaway foods. And we want to make sure that we're having not too much added sugar or refined carbohydrates. So with this added sugar, we're not particularly concerned about the natural sugar that we find in fruit and milk and yogurt. The main purpose of our diet is to help us achieve the blood glucose levels and ensure that there are enough nutrients for both mum and baby during pregnancy and beyond. The main thing that we look at for blood glucose targets is carbohydrate. And when we talk about carbohydrate, we mean both starchy foods and sugary foods. So starchy foods would be things like potato, rice, pasta, noodles, bread, and sugary foods would be both natural sugars like fruit and milk, but also added sugars like lollies, chocolates, cakes. You don't need to cut out the carbohydrate. The baby needs carbs for normal growth and development. And most people agree that we need to consume at least 175 grams of carbohydrate per day. This number is the one that we work off because it's thought to be enough for the fetal brain development and also to prevent ketosis in the mother. The quality is important, so we're aiming for slow release, nutrient dense carbohydrates. So things like rolled oats are a great example of this. We also want to make sure that we spread the carbohydrate throughout the day. So the suggested split for the 175 grams of carbohydrate is 30 to 45 grams for 3 meals and 15 to 25 grams for 2 to 3 snacks, or 30 to 40 grams for the 3 meals and 20 to 25 grams for 2 to 3 snacks. We can create these amounts of carbohydrate using carbohydrate portions or carbohydrate exchanges, which are kind of like building blocks. So they have determined portions of these carbohydrate-rich foods based on this 15 grams of carbohydrate. And we can also use some apps to help us carb count as well. So those carbohydrate portions or exchanges are amounts of foods that will give us 15 grams of carbohydrate. So we can build up our meals using 2 to 3 portions of carbohydrate, which would give us 30 to 45 grams of carbs. And we can build up our snacks using 1 to 2 portions of carbohydrates, so around 15 to 30 grams. We can then top up our meals and snacks with low or no carbohydrate foods like veggies, meat, egg, tofu, and cheese. Examples of what these portions or exchanges might look like. So it could be something like 1 cup of milk, 100 grams of a flavored yogurt. It could be a medium piece of fruit like an apple, orange, or pear, a small banana. It can be things like 1 medium potato, a medium cob of corn, a slice of bread. Um, the crackers tend to vary, so it's 3 Cruskits, 4 Vita Wheats. It can be 1/3 to 1/2 cup of a cereal or 1.5 Wheat Bix, 1/4 to 1/3 of a cup of cooked rice, or 1/3 to 1/2 cup of cooked pasta. An example of what this might look like through the day. So for breakfast, we could have porridge made with rolled oats and then topped with fruit. We could have a milky coffee and a handful of nuts for morning tea. We could have a protein and salad sandwich for lunch with a piece of fruit like an apple. For our afternoon snack, we could have something like 3 Vita Wheats with cheese and then a high protein yogurt like YoPro. Dinner, we could have a cup of pasta or 1.5 cups of pasta with a protein-based sauce and then a side salad. And then a snack before bed could be something like a piece of fruit toast with peanut butter. These are some more examples of what these carbohydrate spreads could look like. So breakfast could be something like a flatbread with eggs, cheese, tomato, or it could be 2 slices of bread, avocado, and a milky coffee, or it could be 3 Wheat Bix with milk. The morning snack could be a piece of fruit and a cup of tea or coffee. Lunch could be a cup of rice with veggies and a protein, or it could be 2 chapatis, 3/4 of a cup of dal, and then lettuce, tomato, cucumber, onion salad. Snacks could be something like 6 crackers with cheese and 1/2 cup of berries, or a small amount of dried fruit like dates with nuts and a cup of tea, or 200 grams of a natural yogurt or a low sugar yogurt with a banana. Dinner could be something like a cup of pasta or noodles with a protein and some veggies, or it could be something like 1/2 a flatbread with yogurt, chickpeas, and salad. Snack before bed could be a cup of milk and a piece of fruit. There is lots of information available to help you work out the carbohydrate amounts in your foods. So there is an NDSS one, which is all about counting carbohydrates. And then there's another one, which is a quick guide to carb counting. There are also apps that we can use to check the carbohydrate in our food. So this one is called Calorie King. It's a free app and a website, and you can search for different foods and it will tell you the carbohydrate content. When you go to the website, just make sure that you are on the Australian database. So if you see the Australian flag down here, you can click on it and it will swap to Australia. We can also use apps like Easy Diet Diary. It's a food diary app. If you click carbohydrate along the top here, it will put a carb column into your food diary, and then it will total the carbohydrate for your meals. This will also suggest an energy target for you, but just ignore it because it's not really relevant in this situation. Talking about our types of carbohydrates, what we're looking for is slow release, nutrient dense carbohydrate sources. So when we talk about slow release, we talk about it in terms of glycemic index or GI. This is a number that's given to a food containing carbohydrate that tells us how quickly the food is broken down and released into the blood. So a low GI food, which is a low number, is broken down slowly, doesn't cause as much of a rise in our blood sugar level, and gives us sustained energy. A high GI food causes, or is broken down quickly, causes a spike in our blood sugar level and then a drop. And sometimes it can cause us to overshoot the target and feel more hungry. By choosing mostly low GI carbs, it helps to keep our blood sugar levels flatter, and we tend to spend more time in the target range. Here are some examples of low GI carbohydrates. So most of our fruit is low GI, apart from rock melon, watermelon, and fruit that's canned in syrup. All of our lentils and legumes are low GI, including things like chickpeas, kidney beans, baked beans. Corn is low GI, as well as orange flesh sweet potato. Most of our white potatoes are high GI, apart from specific types like charisma. Milk and yogurt is low GI, including our cow's milk and soy milk. With our breads, we're looking for multigrain or sourdough as opposed to wholemeal or white breads. And then there are cereals which are low GI as well. So rolled oats as opposed to instant oats. And then things like our multigrain wheat bix. When we choose a food or choose a food containing carbohydrate, we don't often eat just that food by itself. We have them as part of a mixed meal. There are things that we can add to our food or add to our meal, which can help to reduce the GI of those carbohydrates. So we can add fiber, whether that's something like fruit or vegetables or a fiber supplement like psyllium husk. We can add protein. So a great example of that is peanut butter or something like our meat as part of a general mixed meal. We can add healthy fats. So again, peanut butter is a great example of this. And we can add acidity. So something like lemon juice or vinegar. Moving on to talking about exercise. So when we talk about blood sugar levels, exercise really is medicine. It can help to reduce the blood glucose level independent of insulin. So it kind of bypasses that insulin resistance that we're having. Both aerobic and resistant training are beneficial for managing our blood sugar levels. So doing exercise regularly can help to improve our blood sugars, but also reduce the risk of fetal macrosomia, which is larger than average baby, and the need for sometimes the need for medication. When we talk about exercise, we're not talking about running marathons or anything like that. Something as little as a 10-minute walk after a meal can help to reduce that post-meal blood sugar level. With our exercise targets, the aim really is to include some kind of activity each day. So we're aiming for 30 minutes, but this can be broken up into 10-minute blocks if needed. We want to include muscle strengthening activities 2 times per week. The advice for pregnancy is to build up slowly. So if you were active before pregnancy, continuing to do what you were doing before, with modifications as required. But if you were not active prior to pregnancy, we want to start building things up slowly rather than going full steam ahead from the start. Our other treatment, if required, is medication. So some women may need medication along with healthy eating and exercise to manage their blood sugar levels. Many women worry about starting new medications during pregnancy, but it's important to remember that needing medication doesn't mean you've failed or anything like that. It just means that our body needs a little bit more help to overcome the insulin resistance that's caused by the placenta. Insulin does not cross the placenta, so will not affect your baby. And the impact of metformin has been well researched, which is why these are often the two medications that are recommended during pregnancy. So, talking about metformin, this one is a tablet and it works in a number of different ways. So, it reduces the amount of glucose that is released by the liver into the blood. It helps your body to use more glucose or use glucose more effectively by reducing our insulin resistance. And it's usually recommended for mildly elevated fasting or mildly elevated overall blood glucose levels. By taking this medication, it means that our blood sugar levels can be in target more of the time, which will then reduce the risk of low blood sugar level in the baby after it's born. With insulin, there are a number of different insulins that can be used during pregnancy. The insulin is essentially injecting the hormone that helps to move the sugar out of the blood and into the cells. If you've not injected insulin before, a diabetes educator can teach you how to do this. Often we're taking intermediate or long-acting insulin once or twice a day, and you may also take rapid-acting insulin with meals or to bring your blood sugar level down as it's needed. The doses are usually adjusted as the pregnancy progresses. So we've got that increasing insulin requirement, so that dose of insulin usually increases. And it's not that you're doing anything wrong if your insulin levels or your insulin requirements increase. It's just how the pregnancy is working within your body. Talking about members of our healthcare team. So we've got our diabetes educator, and as we've said before, they can start you off with monitoring your blood sugar levels. They can review your blood sugar levels, and then they can make treatment recommendations based on those blood sugars. Our dietitians give diet information to help manage blood glucose levels, but also your overall nutrient intake as well. One of the most important jobs as a dietitian is that they can help you apply the guidelines to your diet. So you're not stuck eating foods that you wouldn't normally eat or foods that you don't like eating. So we can help to apply these guidelines to the foods that you actually like. Our exercise specialists are both our physiotherapists and our exercise physiologists. So physios are the ones that tend to help with musculoskeletal conditions and associated pain. And our exercise physiologists are health professionals that prescribe exercise to help manage conditions. So they can help you come up with a movement plan during pregnancy. Moving on to birth. So what to expect. The timing of the birth depends on a number of different things. So usually if you have type 2 diabetes, they'll recommend giving birth at around 38 to 39 weeks if you're taking insulin or if you're taking a medication like metformin. The main reason behind this is to reduce the risk of birth injury, and a planned C-section may be suggested if the baby's weight is thought to be more than 4.2 kilos. With the medication, so the plan for medication during birth is usually discussed with you in your visit at around 34 to 36 weeks. So once the placenta is delivered, the insulin requirements drop dramatically. So usually metformin is stopped just before a planned induction or C-section, so either the day before or a few hours before. And Insulin is usually titrated during labor or during your cesarean according to what your blood glucose levels are doing. Your blood glucose levels will be monitored during birth and then treated accordingly. So the target range that we're aiming for during birth is 4 to 7 millimoles per litre. So if your diabetes was treated with diet and exercise only, so no medications, the intensive blood glucose monitoring usually stops after birth, and you just go back to what you were doing prior to pregnancy with your monitoring. If your diabetes was treated with diet, exercise, and medication, the medication may stop after birth, depending on what your blood sugar levels are doing. Remember that graph showed that the insulin requirements dramatically dropped and often end up lower than what they were prior to pregnancy. The intensive blood glucose monitoring stops 24 hours after birth if your blood glucose levels are in target, and at that point, you continue with what you were doing prior to pregnancy. Once your baby is born, it will be checked by a pediatrician, obstetrician, and/or midwife, and the baby will be carefully monitored for the first 24 to 48 hours. The midwives usually will perform blood glucose tests to make sure that the baby's blood sugar levels don't drop too low. Up until the next 6 to 12 weeks after birth, the blood glucose monitoring continues as you did prior to pregnancy. You may not start your diabetes medication again straight away. So we've got postpartum hormones and breastfeeding, which both produce our insulin requirements. Make a plan to follow up with your GP or your diabetes specialist in those first 6 to 12 weeks, and often they will discuss contraception with you prior to leaving hospital. We've got some helpful fact sheets here, so particularly about our carbohydrate counting and our portion sizes. These are the ones that I showed earlier in the presentation. And then we've got our references here as well. Thank you so much for tuning in and listening to our webinar on type 2 diabetes and pregnancy. If you have any questions, please feel free to send them through and we'll get back to you with a response.